All right, good morning, everyone. I just started the recording for today. It is March 21st, 2025. We are meeting as the Sexual Assault Response Network Committee, and thank everyone for being here. We have a quorum. We're not going to do our usual start of the meeting with our round robin, checking in with member notes on things that have been happening since our last meeting, just because we're on a little shorter time frame today. So I'll just be taking and noting the roll here from the attendance list, but I did want to give an opportunity to our new Bureau Chief, Derek Malum, to introduce himself while he's with us. We've had a reorganization here at the Department of Justice, and our Office of Victim Services is now under the we're still within the Division of Criminal Investigation, and we're now in the Criminal Investigation Bureau, and Derek is our new Bureau Chief. And so, Derek, do you want to go ahead and introduce yourself? I didn't give him a heads up, so we might do that in just a minute if he had to step away for a second. So apologies for that. But welcome to everybody else. We have our guest speaker today, Sarah Wangerin, who is a PhD candidate with the Montana State University's College of Nursing, along with other hats that she wears. But I will ask her to introduce under which hat she's wearing today so that it's clear and we don't cross any lines that shouldn't be crossed in identification. But we're very glad to have her with the literature review that she's been doing about SARN programs around the country, looking for pros and cons and successes and lessons learned and things to share with us as we think about how SARN programs are structured here in Montana and forensic exams for sexual assault survivors. Just a content warning before we get going. A reminder, we will be talking about extensively things related to sexual violence. And so for anyone listening today, just a heads up on that content, and that if you need to take time away to, just take a step out, whatever it is you need to do for your mental health and to protect yourself, please feel free to do that. As always, we want to remind everyone that there are resources available for mental health counseling on our website, and other resources, referral resources for victim advocacy in our resource library. And so just encourage everyone to check out our website for links to those resources if you're needing some assistance, or you can always reach out to us here at the office too. And so today, Sarah Wanger, I'm going to turn it over to you now. Thanks so much for your presentation and joining us.
Thank you so much for having me. I'm going to attempt to share my screen here. Hope that you can see it. Perfect. Can you see it okay? Is it there? Okay, wonderful. Thank you. Well, thank you for the introduction. I do teach nursing at MSU, but I'm not officially representing MSU today. But I was an emergency department nurse and a sexual assault nurse examiner for adults, adolescents, and pediatrics prior to starting to teach nursing. And I also work on the HRSA grant at MSU, and where we're trying to train more SARN nurses in the state. And I am, like you said, a PhD student studying SARN systems of care and access and policies and mandates and things like that. So I'm glad to be here today. Some of this you all might know already, and some might be new. So I apologize if I'm preaching to the choir, but I did a review of the literature, and unfortunately, as we probably could guess, there's not a huge amount of literature about sexual assault programs and systems of care, right? There's a lot about training and different barriers, but not really focusing on systems level factors, especially in rural areas. And so that's, definitely needed more studies in this area. But themes that did emerge were telesane, staffing models, some different options, mandates, funding, and then community and stakeholder support. So I'll talk to you a little bit more about those. And I understand you're going to kind of focus on telesane later, but a lot of articles talked about telesane as a solution that is being utilized in many different states. I'm sure more than just these that I've listed, but those are the ones that I had articles in front of me about. It typically utilizes a hub and spoke model of care. So they're kind of a centralized group of experts who then are contracted to different facilities and provide care 24/7 and support. And different states do it differently. But generally, it's really well received in the literature. The nurses who utilize it report increased confidence in evidence collection. It's been shown to statistically improve the quality of the exams and the care that's provided. It helps patients stay in their area so they can avoid long wait times or long transfer times. And in facilities where there might be, only female RNs and a male patient presents or vice versa, it's helpful to have that option, as well as an agency that might only be staffed with travel nurses who are from out of state and maybe don't know the laws of the area. Some of the barriers are it is expensive to start. Different systems utilize different technologies. So some of them are proprietary systems you buy, like a cart and a setup and everything like that. Sometimes there's physical limitations to where people are doing the exams, right? The space in the room. And so that might be a barrier in some areas. Reimbursement levels, which we'll talk about later, but that's also important to note. And then just people being comfortable using telehealth, which obviously comfort with telehealth has increased immensely in the last 5 years, but that's one concern to note. And then whether or not there's the IT infrastructure in some rural areas to support using telesane was one issue. But the facilitators are really if there's a great, robust initial investment and then an ongoing funding structure. So a lot of times these programs might be a mixture of contract payment, reimbursement from the state, and then grant funding. And two, I would just highlight are the safety system at Penn State. That's a well-utilized system. And then TexTrack at Texas A&M. Those are both pretty big telesane programs out there. So other things that we found in the literature were different staffing models. And I think you all know, but of course the gold standard is that when we would have someone present for care, then they would be able to receive the care, right? And the IAFN and the ENA have a joint statement on having someone trained in evidence collection in every ER, or having all ER nurses have some kind of training, not necessarily the full training, but being able to provide trauma-informed care and help with forensic evidence collection. So different models were explored in the literature to try to meet different needs of environments. One was to have dedicated on-call staff, which many programs have. But there's expense to that, right? And so having that on call 24/7 is one option. Having a pool of responders who respond to maybe different hospitals in the area and aren't just working for one. So there's not a duplication of services was one other option. Using telesane consultation was another one discussed. And the literature does report, and we can kind of verify that it does cost about $3,000 to train a SANE, to have someone be fully trained to go through that training. So obviously that is something to consider as you're looking at different staffing models. And some of these articles are actually written by business professionals trying to work it in that angle. So there is no one size fits all, certainly in the literature, to meet different geographic needs or population needs. And there also is no number that I'm aware of like here's how many SANEs you should have per capita or per geographic area. That just doesn't seem to exist. So we know that barriers to staffing are, of course, funding, which again, we'll talk about. The other barrier that has mentioned a lot is that this is something you're asking nurses to do in addition to their full-time job, right? So if we're asking them to take call shifts, most of them are working another full-time bid, and then they're being asked to do, maybe 5 call shifts a month or something like that on top of it. And so that can be a real barrier. Geographic challenges, of course, like having a pool of nurses would be great, but if the pool is driving 200 miles, then that's a challenge. So sometimes that's not feasible. And some of these models don't lend themselves to people having a lot of exam frequency, and that really leads to decreased confidence and competence when they're doing exams. So that's something to consider when you're creating a staffing model, is how many exams will someone be seeing. Big thing in the literature is funding, of course, which I am going to guess you guys talk about, and kind of 3 different buckets that falls into funding to develop and maintain a program. Often it's grant funded, but of course that's limited time money. And so how do you get your program from grant funded to sustainable? That's a challenge that programs face. Another bucket is kind of how do you pay your staff in a way that can help your program maintain viability. So are you giving them on-call pay? Are you staffing a coordinator? Are you offering some kind of flat fee for exam? Places do all different options, and there are some places that don't pay their staff. These are just done out of goodwill, which of course would not be ideal. And then different reimbursement structures. Because the mandates vary state to state as far as who is funding it, it's difficult to talk about it in a broad way because every state is different. Some states do pay for all of the fee of the exam. Some really encourage you to bill insurance for some parts of it, and that's a real challenge when you have a patient who maybe doesn't have insurance or doesn't want that EOB showing up at their house. So there's all sorts of things around funding, and it's kind of a mess to untangle on its own. Basically, the overarching theme is just they need more funding, and that the current levels of reimbursement are not helping programs be sustainable. And as I mentioned, even telesane, the literature talks about hospitals wanting to be contracted with those services, but that if they have a low exam frequency, that they really need grant funding to supplement that because it's not sustainable otherwise. So mandates, a lot of states play with, mandates for care. Should it be mandated that somebody is in every ED to receive these patients or not? And I have to say, of course, my bias is that when someone shows up, there would be someone there who is trained and can take care of them. The reality of implementing these mandates is that while well-intentioned, they don't end up increasing access to care, is what the literature shows. It's if they create a mandate without increasing funding levels or providing some other supports to these programs, it doesn't end up increasing the frequency of exams in rural hospitals. Patients still end up transferring or not getting the care. But the flip side of that coin is that when there is no mandate and there is no requirement to provide this care, then hospitals don't have to provide the care, right? And so if there isn't other buy-in, they just won't do the thing. So the literature kind of says we need these mandates, but we need the mandates to be funded and really well implemented. I have more specific information that I can't divulge right now because it's a preprint article that I part of, but I can tell you that most states don't have any requirements at all about who performs an exam. They don't, they don't even qualify that it has to be a healthcare provider. There are some who say it has to be a healthcare provider, but they don't define what that is. There are others who say it has to be a healthcare provider who is trained, but they don't describe the training, or it's very vague. And then there's others who are very particular about it, or others who defer to like the Board of Nursing or different medical boards to define it. And so it's very kind of loose and vague, and even when there's something there, it's difficult to quantify and difficult to enforce. So it's like I said, it's a step in the right direction to have mandates, but how those mandates are written is very important, and sometimes doesn't pan out the way you wanted, which we saw in the Texas mandate in particular. So the last piece I think in there is that really the things that you need to sustain the will to keep the programs going is you need to have hospital administration buy-in to the program. And if you have a lot of turnover at that level, sometimes you'll have somebody who really champions the idea and then isn't there anymore. And that makes it difficult to sustain it because of all these other barriers, right? It's a really messy kind of thing to try to build. So that is one really helpful item, is if you have that C-suite buy-in. And then of course, nursing staff and management support. You need to have the bedside nurses either wanting to be trained or wanting to take over for somebody else when their counterpart is doing an exam. Really understanding why this is important to provide this care and that it is a team sport, and having management support of saying like, hey, we really do need to use this telesane option here. Let's get more comfortable using it, because as we know, if someone doesn't feel comfortable using it, they just won't. And that's why so many new innovations just go to the wayside in medicine, right? And then community engagement and awareness. The more communities know what is or isn't available, the more willing they are to engage. So I think most people believe that when they pick up the phone to call 911, someone's going to come for them, right? And that may or may not be true. Maybe it's a busy day, maybe there isn't enough staff. There's a lot of things that go into that. The same thing is true here. If you assume that this service is available and then you have an experience and you find out, oh my gosh, it's not, or it was available, but it was 200 miles away, that kind of spurs communities to realize the gaps that exist and makes them more aware of how they could engage. And if you have community stakeholder buy-in, that really helps to continue these programs and keep them going. So a lot of community awareness and engagement is part of what really sustains those same programs. And then I have a plethora of references, but these are the ones I cited in the presentation today. And I hope that's somewhat helpful. And I'm happy to answer any questions if there's anything you think I would know.
Thanks very much, Sarah.
Yeah,
I'm
you're
gonna
welcome.
stop your screen share here so we can see folks' faces a little bit better in the meeting. I imagine there are some thoughts people have, and I wonder if anybody is interested in asking a question right now or has a comment or feedback they want to offer.
I have a question for Sarah. So I know you had said that you can't divulge some information regarding a study that you're in, but do you know what the requirement is in Montana for conducting a SANE exam?
Hope can correct me, but I don't think that we have a requirement.
Okay,
Yeah, I don't think that we have a state statute that says it has to be a healthcare provider or it has to be any kind of training right now.
Yeah, and that's been my continued understanding is Montana doesn't have a specific requirement for who does the exams.
okay.
Sarah, early on, you mentioned something about the quality of exams in relation to telesane. Can you tell me a little bit more about that research?
Sure. Yeah, there's a lot of studies that talk about that. There's one from 2014 that I'm pretty sure I'd have to look back and verify is focused on pediatric exams in particular, where they found an increased quality of evidence collection in using telesane. And then all of these programs that use telesane or have telesane programs do ongoing studies, qualitative and quantitative, looking at increased quality of evidence. So I believe, and again, I'd have to go back and read these specific studies again, that they were looking at quality of like picture quality, actual evidence collection quality increased, and then also patient satisfaction with the service was great. So I think it's 91% of the patients, at least in the Safety Center, which is at Penn State, who are offered the telesane service opt in. And even if it's not for the full exam, but at least for some part, so nurses could call in and say, I have a question about this, or I'm not sure if I need to collect this, or they can be there and consult for the entire exam. So there's different ways that they implement it, but overall it's shown to really help nurses feel more confident and comfortable conducting the exam, and then provide assurance that the exam is being done well.
So that's an option with every SANE exam in Pennsylvania under the safety program.
Every hospital that contracts with them, yes.
Mm-hmm.
Yes.
And then who staffs that telesane?
They have a core staff of certified SANEs who take call, I assume, that staff it, that are available for those calls. And I believe TextTrack is the same. And I think that in Texas, it might be that they're supposed to all call into TextTrack and they don't. It was a little unclear to me if that's still what's happening. So that's a little different implementation. But definitely in Pennsylvania, I know that it's a contracted service. It's optional.
Sarah, in your research, did you get any indication as to why a state would choose not to have a definition of who can provide service?
That's a really good question. No, I don't know that there was a reason why. Other than I think some states are just more motivated to carry this forward than others, or maybe have a champion behind it than others. And I think sometimes if people don't know how specific they should be or how broad they should be when they're writing a piece of legislation like that, maybe they don't know, like saying healthcare professional is really broad. And so you really need to narrow who you want doing that exam. Or even saying they need to be trained. Okay, cool. Do you mean like a 2-hour training or do you mean like a full training? So I just think it's probably not having the right people at the table who know maybe driving that forward. So yeah, there's not a why, but I do know that they just don't. That's a good
That's
question.
interesting. Mhm.
Yeah.
Thank you.
Mhm.
Other questions, comments? Sarah, I was curious about Texas's experience when they rolled back, or I think I heard you say they rolled back the mandate to be able to provide care. Could you talk a little bit more about the challenges they experienced?
Yeah, I have to look back now and see where they're at. Are they still attempting to mandate or not? So they implemented that first law, maybe 2017, maybe 2014. I can't remember because I've done too many references now in my mind. But when they reevaluated it, they found that because the burden for training didn't change, right? That still fell to the individuals or the facilities. Like all of the things they mandated just weren't funded. That these hospitals couldn't meet that burden. And so the point was to decrease transfers. It actually started because a legislator read a news article about a woman who was assaulted. Her sister took her for care, and she went to 3 different facilities before she found a facility that had a SARN available. And so that was 50 miles of driving. And I'm thinking 50 miles in Montana is nothing, but still a burden for this patient, right? And how frustrating that was. And so they thought, well, if we mandate that everywhere, every hospital has to provide this care or has to explain to patients the care, that will increase care. But it just, the way that the legislation was written, it didn't work out that way. And so patients were still being transferred. And even up until the last article I read, was I think 2023, they still are struggling with sometimes facilities not feeling comfortable and just opting to transfer a patient instead. They are supposed to give the patient this document that says we're not a safe facility, like we're not a sane facility, but you can still have an exam here, or you can opt to transfer, and here are your options. They're still losing patients though, from point A to point B, right? It's not like we're tracking, did they show up at the transfer facility or not? And sometimes that's just, I mean, that might be what's best for the patient to transfer them sometimes, right? We know that we would like them to have the best quality exam available, but sometimes it's probably just that the facility isn't trying to meet that burden, or it's, there might be a barrier to them meeting that burden. And so it just seems like we need to look at those factors that are leading them to send these patients off instead of, penalizing them or just making the patient transfer. Yeah. So it's still a problem. The telehealth does help address that though, right? So that is one layer where they're coming in to say, hey, you can have this support and you can do the exam in the facility that you're in.
And they're finding that with just the nurses, not the SANE trained nurses, or not people with a background in SANE or safe training. Just any of the ER nurses are being reassured that they can do the exams with the help of the telesane.
In some places, yes. In some places, they do have requirements for the people who are doing the exam and utilizing the telesane. So they still have a burden of the facility has to train someone in minimally training in different, like an evidence collection and things like that. So that's very state specific as well, as far as like, is it, any ER nurse consulting with them, or is it that you have to meet some kind of burden of training for the people utilizing it? Yeah, they have some requirements for that. I think Texas's requirements are more stringent than Pennsylvania's, if I recall correctly.
Yeah, Brenda?
Thanks. Hi, Sarah.
Okay.
I was curious if, in lieu of legislation, do they discuss following like the Association of Forensic Nurse Examiners recommendations for like training and protocols and things like that? So at least they, are following like a national organization without having that specific legislation and guidelines per state.
That's a good question. The states that don't have any language about it, no, they don't. The states that talk about training often reference some kind of standard. Yeah, they talk about either like a 2-hour training or some of them delineate what that looks like as far as like a 40 or 41 hour or whatever training, which would be kind of the standard. But a lot of them just don't have anything that addresses it at all. There's nothing. Yeah, that's a good question. And in some of them too, I should mention that sometimes there are laws that are a barrier to using things like telesane. So sometimes there, that's something that to think about is, crossing state lines or, how are people, how is that being implemented? That can be a problem.
Sarah,
Mhm.
Sarah, this is Ben. And as an administrator and looking at both sides of this, as both the need for SANE being spread out across the state, as well as the demand and the availability of nurses and SANE trained, are you seeing more traction within legislature to get funding or grants to help support smaller facilities, to support the training as well as staffing for SANE and have it available?
That's a good question. I think it really varies state to state. Yeah, there are some states that, fund exams at a higher level and that cover all of them. So there's no like the law enforcement does it or FREP does it, they cover them all. I would say there's not a lot of states that I've found that robustly cover the training. That's typically not something that I've found covered. But as far as supporting hospitals having the programs, I would say that's still hit or miss. I don't think that there's a huge recognition on a bigger level. I think that like hospital administrators and our state recognize it, right? And there's definitely programs in our state and people want to be trained in all of those things. But I don't think there's an overarching recognition of the barriers to actual implementation, if that makes sense.
Yeah, and I think it's the implementation and the staffing and even having staff on call for it.
Yeah.
The expense of having them on call and availability of staff, that piece is even a burdensome to facilities to have them on call. And I didn't know if there was any traction to get grants or funding for that.
That's a good question. I don't know of any. Like the grant we have is focused on training, and that's great, and we need that. And that's not the only barrier, right? Like that's actually a barrier you can fix. You can train people and you can do that. But the other things, as far as sustainability, I would say no, there's a lot less available for keeping nurses in who are trained. So retention and then meeting the needs of, covering staff when they need to go get trained or covering call pay or, like those structures that actually, and that's why some of these articles are interesting because it was actually like laying out different plans of staffing models and asking different hospital administrators like what works. But even then they aren't really focused on rural areas. They're focused on kind of bigger systems. So that's a very different problem than, somewhere where you have maybe one person trained in a, couple 100-mile radius. How do you meet that need? Yeah.
Yeah, and prevent burnout of the one or two people that are trained and prevent burnout of the call burden as well as the burden of coming in and performing the exams.
Yes. Yeah, totally. Which is, I think it'd be great if, if we did have people who were minimally trained and then could utilize, like maybe like you have a stroke call system or something kind of like that, where you could utilize telehealth, and someone could just be the arms, you know, and be the physical person in the room. I think that most nurses could be trained minimally and then utilize the experts when needed. I think that that would be one helpful solution for a lot of areas, but even that costs money and takes time.
Yep. Thank you.
Yeah, thank you.
Sarah, could you, sir, maybe we're getting into telehealth more than we anticipated today, but do you have any observations on the types of technology the telehealth programs are using between states? How, I don't know the right words to use either. Mark and Ben might have better words, but just how complicated it is, or if it's, you know, simple solutions, or what's the.
That's a good question. I don't know for sure. I know that Penn State's system has its own way of encrypting or whatever. I don't know the word. That's not my wheelhouse, but you know what I mean? They store the pictures. It's its own system. And so I think it's pretty small and minimally invasive system. You know, it's not like a big thing you have to implement. And so I think different places have different. I know that there's a system out of, I want to say, South Dakota. You know, there's different options and models. That some of them, you know, really become the storage of the data, and they can kind of take away some of those concerns of confidentiality and all of that. I think there's also a colposcope that is like that too. That is, I mean, it's very expensive. I can't even remember how many zeros were behind the two, but it's at least $20,000, but it has that same idea of it encrypts information. And so I think those solutions exist. Could you maybe get a grant to purchase something like that? I bet you could. Could you sustain, you know, that for every hospital? I don't know, but yeah, different systems of telesane care, I think, have different technology that's kind of proprietary to them that they use.
Any other thoughts or questions? Yeah, Brendan.
Not that I'm promoting one brand over another by any means, but Cortex Flow is a fancy system for doing exams. They do have what's called Cortex Flow Live. So kind of building in that component of being able to do that real time. And I don't know a ton about it, but I'm happy to share the information that I have.
Yeah, I think that's the brand that I was thinking of for the fancy colposcope that you can travel around with. I think it fits in like a suitcase or something. I don't know. It looked really cool and also very expensive. So I don't know.
Any other questions, comments on this portion of today's agenda? Yeah, Kayla does.
Were there any factors related to the C-suite buy-in or strategies?
Oh, strategies to help with that? Is that your
just,
question?
I know that was one of the, like along with the nursing staffing and management, there's just hospital administrative, support. And you'd mentioned people, the turnover in that, that may impact the next leader in that organization. But for the people that are bought into this, are there any strategies or methods or factors that influence that?
That's a good question. I didn't mention that. So I can't definitively say, the data says this. I think, I mean, my guess would be that either it's because they are good people who recognize that there's a gap in care and they want to do the right thing, or they have a community that pressures them to do that, is my guess, right? That there's enough community outcry to be like, hey, this is what's happening. because even with what I know and my experience, I will run into people who will tell me things that have occurred, and I'm like, yeah, why didn't you know that? Or I already, and they just have never interacted. They've never had this. Thankfully, they hadn't had this experience before, but now that they have, they've tried to navigate this complex system, because healthcare is complex anyway. And this is not just healthcare, but it's healthcare and law enforcement, it's healthcare, and it's all these things together. And so I think that once people are aware that the care that they think exists doesn't, because I bet if you ask most people, and this is something else interesting I'd like to study, but I don't have this much time. But I bet if you ask most people, they would assume that that if something happened, somebody knew what to do, right? That if they showed up at their local ER, someone's going to be able to figure this out or help them. And it's just not true. And that doesn't have to be a big city or a small city. That can happen anywhere if you just don't have that program. And so I think after those things have occurred and there's some kind of awareness in the community, that kind of spurs it. Or you have a champion in the facility who is really passionate and who kind of brings it forward and doesn't, let go of it, which I would guess is what's kept the programs going in the state that have been successful in long term. They have a really strong champion, right? And I know that you have people here today who are those people, right? Like they wouldn't have the programs there if they didn't have these people who just really, really believe in what they're doing. I think that the same thing exists in the C-suite, right? Like you have people there who, for whatever reason, they feel like this is the right thing to do and they do it. And then there's some communities that just really drive that as well. But I don't have a really lovely data point to tell you, which I wish I did. I wish I had data for all the things I want to say, but I don't have that. So.
No, thank you. And we so appreciate Ben just being in here and in his capacity and sharing his expertise and just being at the table. And we just thank you for that.
And Sarah, being in the C-suite and also nurse background, it is a very complex one, balancing the many aspects within the C-suite of the demand for the care and knowing what is a demand. It's a very low demand, thankfully, in many areas, but balancing that with the heavy resource dependent that it is, and how do you balance that within the facility and balance that amongst all the other needs across the facility. That is the biggest piece and the headache that C-suite members have, and trying to balance those pieces. You have a program that's a low volume, high resource compared to other services, and trying to figure it out. And that's the hardest part with this program, and knowing it is the best thing for the community and something that you do need for the community, but how do you fit it all in? And that's kind of where my questions were with the resources and grants, and how do you get some relief for the facilities that do need a little bit of support and help to get the programs up and running for the community, and how can we get those kind of support for the community like that?
Yeah, and I totally appreciate that. What happened in Pennsylvania was they rolled out their original telesane. Then they kind of worked it to be a sustainable model where there was a contract so that they could not always have to have grant funding. And then when rural facilities felt like they couldn't do that, then and other facilities felt like they could, that kind of helped offset that, kind of getting a payer mix, right? Like we do in healthcare, that helped to carry the facilities that couldn't afford it, basically. And so that could be a model as well, like kind of this mixture of payment systems and high volume facilities perhaps offsetting some of that cost with the low volume facilities.
Yeah, in reality, grant funding is great, but we know one of the main questions they ask when you have grant funding is, what's your sustainability plan when this grant funding runs out?
Yeah.
And I never have a good answer for that.
Yeah, exactly. It would be nice if you didn't have to constantly do that, right? And you could just focus and not constantly be trying to get out that grant pool. Yeah, great.
Anything else? Anybody? Okay, Sarah, before you go, I wonder if we could just touch briefly to switch hats, and maybe I could say the things so that you're not wearing a hat you're not supposed to be wearing right now in case. But I just wanted to share, there's been a lot of work by the MSU HRSA SARN training grant team with the Montana trainers and working on Montana-based opportunities, but also leveraging the grant money they've received to help nurses get through the IAFN online course right now until we can get a Montana didactic course up and running. But in the meantime, we have in-person clinicals that are scheduled. There is one 2 days for each of the adult adolescents. There's one in Miles City, April 14th and 15th. And right after that in Billings on the 16th and 17th, there's another 2-day, and that's trainers from out of state coming and pairing with some Montana trainers who are on this committee right now in the room. So we thank them, Whitney and Emily, for taking that up and doing the train the trainer efforts. And then Whitney and Emily are going to be working and partnering with the MSU HRSA team and Central Montana Medical Center in Lewistown to offer a 2-day in-person adolescent and adult training July 22nd and 23rd, as I recall. And then there are some other dates and possibilities in the works, but these are the ones that have been announced. And as I heard last week, they were pretty full already at this point. That Lewistown one just opened, so there's still some room there, but lots of interest. Sarah, do you have anything you want to add?
Just we're also having a pediatric training May 5th in Billings. So our first pediatric skills day. So yeah, a lot of
And it's
exciting.
exciting because
Yeah.
that's the first in-person pediatric training we've had in quite a while in Montana. And that's
Mhm.
partnering again with an out-of-state organization that does
Mhm.
pediatric training in Indiana,
Mhm.
coming here and doing that. So we're just really grateful for those opportunities. So.
Yeah. Yeah.
Okay. Great. Well,
Thank
thanks so
you.
much for your time, Sarah. Really appreciate it.
Thank you so much for having me. I appreciate all the work you all do. So thank you.
And if you want to stay and keep listening, you are welcome to. We will not kick you out. So. I'm on board next to talk about some follow-ups related to the forensic rape examination payment program and the discussion we had at our last month's meeting around the Government Accountability Office report on how other states are paying for exams. I do want to offer a couple of quick updates though before we get into that information, since we have a couple of minutes here technically. So I just wanted to let you know the new updated Montana sexual assault evidence kit is in stock. It came in right before our last meeting and has been out getting to the medical facilities. And we know that as of last week, we've got 3 or probably 4 facilities now using those new kits. So that's really exciting to see them rolling out. And I think generally people are excited about them and think it's going well. So that's great news. And so just really happy about that. Turning now to sexual assault forensic examination payments, I'm going to bring up my PowerPoint, and I've got to do that quick little jig jog here to get my PowerPoint and the screen timed in the room here for the folks in Helena. So Derek, while I'm doing that little technical jig, would you mind introducing yourself to the group as our new bureau chief? He was having a little technical difficulty when we called on him last time, so I wanted to give him that opportunity again.
Little bit unsuspected. I'm honored to be a part of your guys' committee and your group. And a little bit of background on myself. I retired from the Great Falls Police Department, did investigations for several years, primarily in the general crime side of the house, but also worked hand in hand with not only just sexual assaults, but child cases, and had several pretty horrific cases in the background. So I appreciate the focus that you guys are doing. I saw it firsthand out of Great Falls when we had to drive one of our victims clear to Helena to have a rape exam done or a sexual assault exam done. And I hope that we never have to ever do that to a victim again, period. And you guys have made leaps and bounds, improvements across the state, and your media or your work is unbelievably impactful. So I'm truly here to learn. I'm not a very good speaker and presenter and all that kind of stuff. So I look forward to the relationships and the new forward movement we're going to have going on. So I appreciate you guys letting me pipe in today.
Well, thanks for being here. We're so glad to have you as one of our team members, and appreciate your advocacy for us too. Let's see, Emily or pardon me, Whitney or Kayla, do you mind running down to the door and waving outside for Emily? She's here to come. into the
Oh, yeah, she's
building.
next to me.
Yeah,
Okay.
thanks. All right, so I'm gonna get this screen share going here, and hopefully everybody's gonna see it all at the same time. So I'm gonna revisit just quickly to remind us of the underpinnings of how Montana is billing for sexual assault forensic exams currently. And a reminder that it is the Federal Violence Against Women Act that requires forensic exams be free for victims of sexual assault. It also requires that they have the opportunity to have them. They can't be prevented from having them. And so Montana statute was enacted in 2005, and to set up how we would address that. And what the legislature established was that law enforcement would pay for sexual assault forensic exams when the crime is reported to law enforcement, and the Department of Justice Forensic Rape Examination Payment Program, known as FREP for short, would pay if the assault was not reported to the law enforcement agency, because the VAWA also requires us to have an anonymous option. And so we know that there are lots of reasons people don't necessarily report right away, but would like to at least have a medical exam to check on the health of their body, and have potentially evidence collected so that it can be held and used in the future if they do decide to report to law enforcement later. And that PrEP program, both the administration of the kits, the payment for the exams, the storage of that evidence in those anonymous cases that are not reported to law enforcement, all is housed under the Sexual Assault Response Network program umbrella that I manage. And then just a reminder that patients may still be billed for the cost of the treatment of injuries. That is what the state legislature allowed, but they cannot be billed for the cost of the forensic exams themselves and the collection of the evidence. And we're glad to have Emily join us here in the room, so good to see your face. So moving forward in this conversation here, see, I've got to make sure I'm changing the right things. What am I changing? There we go. So you were interested in learning more about the underpinnings of FREP with the statutes and the administrative rules. I did send out in your meeting bug links to the current statutes and highlighted some of the most pertinent provisions. I've summarized those here on this page. So the first thing in Title 44 is your SARN committee duties, and just reminding ourselves that they do include establishing and reviewing payment amounts and processes and considering the current structure. So we've been doing that. We know that the legislature has a proposal related to this that's come up, and I'll talk about that in a few minutes. But this is, again, just why we're talking about it as a committee, because the legislature specifically asked you to review the structure. And in Title 46, Chapter 14, 404 there, this is where we have the language that says kits not reported to law enforcement are forwarded to FREP to hold anonymously. After that, we have one 406 that says this is the victim's rights statute, and that is where it's laid out by the legislature that they absolutely have the right to have that sexual assault forensic exam and evidence collection, even if they don't want to report. And it also says there they may not be billed for the cost of the exam or collecting the evidence. Layered with that next is 4615.411, which says that law enforcement pays for reported exams and FREP pays if there are funds available for non-reported exams. It does allow that the Department of Justice in that statute can identify priorities for funding exams and criteria for receipt of funds by the medical facilities. So that's where we ask you for an invoice, for instance, for the exam, et cetera, and other documentation. And then it also allows the Department of Justice to adopt necessary rules to implement this payment structure. And so those administrative rules are what we'll be looking at on the next slide. 411 is also the statute that talks about law enforcement agencies and FREP are not required to pay for the treatment of injuries. And then the last statute we wanted to be sure to point out was the retention of evidence statute 4615.413. which says that we have to store the evidence in a secure and reasonable manner that preserves it for 75 years. Or until, in our case, the PrEP program, until the victim reports. And so that's the quick rundown on the statutes that underpin PrEP. Any questions on those before we move into the administrative rules? Celine, anything as an attorney that you'd want to add in relation to those?
No, I don't think so.
So moving over to the administrative rules, now again, I said the PrEP statutes were adopted by the legislature in 2005, and then subsequently the Department of Justice took that rulemaking authority they were given and adopted the administrative rules, and they have not been updated in 20 years since that happened, and we know it's high time. And so did the 23 legislature, and that's why they gave you this job. What I've done is I went through the rules. I gave you a link in the meeting bug that had all the rules in their raw language, rule by rule. This slide here just summarized the still current provisions that we're still using and operating with. And then we have several outdated provisions that have gone by the wayside and just aren't being used at this time. And so there are many updated things that we should be doing if we look at updating those administrative rules. The still current provisions are the basics that PrEP provides medical facilities with the kits at no cost for the collection of the evidence. We're reimbursing for the exams. When a kit is collected, we are not able in PrEP because we've never had a dedicated budget to have enough funds to pay for exams where a kit is not collected. So we are not paying for those. The administrative rule says there has to be a kit collected, although it still does not have to be reported to law enforcement. Our maximum payment currently is $600 per exam. And then there is a statute that, an administrative rule that lines out what those covered exam costs are. And I'm sorry, my notes are covered up, so I can't look at them quickly, but some of the basics are, just the exam room, the cost of the nurse or the provider, the evidence collection, medications, labs that might go along as we look for STIs and those sorts of things. There's a list, and I can you can
Shipping costs, laboratory testing, toxicology testing, medical provider charges, emergency room charges, and then whatever else, the other things you mentioned.
Yeah, thanks, Whitney. I appreciate you adding that in. But it is all in that link in the meeting bug to the administrative rules. You can look at it in detail. The other thing the administrative rules stipulate is that the PrEP payment of $600 max per exam constitutes full payment. And so the medical providers may not go back to the victim and bill them later for covered costs that exceed the allowable payment that we can make. So that's part of that financial gap that medical facilities are experiencing. It does stipulate, again, in PrEP, reiterates what the statute says, which is that we do not cover costs for treating injuries. Those are the victim's responsibility. And then lastly, the administrative rules that we're still holding to is that PrEP holds that evidence and information confidentiality, and we relay those cases, the evidence, to law enforcement if they're later reported to law enforcement. The outdated provisions, the first one is just a change in practice that's come with the evolution of forensic exams. The timeline when a kit is collected to be eligible for reimbursement from PrEP used to be 72 hours, but we're doing exams. The national protocol and guideline is 120 hours, but also leaves flexibility for examiners based on the specific circumstances of that case to go longer than that even. And so we at PrEP are not adhering our payments to the 72-hour guideline anymore for that reason. If the kit's collected, we believe it's in the forensic examiner's good interest as to why they did that, and will reimburse for that kit being collected. We do need to update the address to which collected kits are sent for PrEP and where the invoices come. And so that's a bit of housekeeping that needs to happen with updated administrative rules. We also used to give advice on more specific advice on how shipping should occur. We recommended overnight in the past, and that's not the case anymore as long as there's a tracked shipping method that's used so that we can track it if we need to, if something happens. Forms that must be submitted have changed. We used to have a separate claim form for PrEP, and the kits, the Montana 100A kit, which is quote unquote the old kit now because we have a new kit, that still has a separate claim form that we've used, and facilities can continue to use that. But the new kit, that claim form for PrEP and the patient information when they consent to the exam is combined in one form. And so we're getting that updated form now. The kit retention timeline has certainly changed. It used to be statute told us that we held FREP kits that weren't reported to law enforcement for 1 year. And the 2023 legislature increased that to 75 years to match the evidence retention guidelines for major cases. And so that provision in administrative rule is certainly outdated now. And then lastly, there was also a rule that FREP would recoup exam costs from the law enforcement agency to which a FREP case was later reported. And I don't know that ever actually happened, but it's not something we've done for many years. We have not in recent practice been going back to law enforcement and saying, hey, this case was turned over to you. We paid that bill originally. Now you've got to pay us back. We're just not doing that. That's, I think we've just said that's more than we want to do with law enforcement agencies and not worth the hassle or experience for everybody. So
Hope on
Yeah.
that point, I have had the experience where maybe a patient had said that they wanted to go the FREP route on Friday, and Monday they decided they were going to report to law enforcement. I have got notice from FREP saying this case was reported, please send them the bill.
that's true.
Yeah.
We are doing that as long as we haven't issued a check or a
That
payment
makes sense.
or
Okay.
processed it. I'm roughly processing payments on a 30-day timeline right now, as long as I have the invoices from the medical facility. The invoice does have to be submitted to receive payment. But I will let the medical facility know if a report's come in and we haven't made a payment that we'd like them to bill law enforcement. So there is a piece of legislation, Senate Bill 491, which I've been communicating with committee members about. And this was introduced by Senator Phelan from, he lives just west of Glendive, I believe. He's out in eastern Montana. He had a constituent who has done forensic exams in the past at their medical facility and advocated for a bill that would change and update the payer system here in Montana for forensic exams. And really what the bill does is it establishes a fund from which reimbursements would come. We have not had a dedicated fund to date. We've been paying for those exams not reported to law enforcement out of our crime victim compensation budget. And if you have more detailed questions about that, Kayla is here to share that with you if you're interested. But the way Senate Bill 491 anticipates the fund being used is it would transfer $375,000 from marijuana tax revenue funds to that account to pay for exams. That portion of the marijuana taxes are the portion that are not allocated to other purposes currently in statute. There are things that percentages, for instance, of the marijuana revenue automatically is allocated for. The portion that this would take the funding from is from the chunk that's not allocated to a specific purpose and instead currently goes to the state general fund for whatever use. And so this would take that piece out of the state general fund and allocate it for this purpose. The bill creates a single payer system where DOJ would pay for all of the exams, regardless of whether they were reported to law enforcement or not. And law enforcement would no longer be responsible for the cost of the exams. And so that would require some work with medical facilities, make sure everybody, had that outreach on the updated change. And then lastly, it establishes a maximum payment for an exam of $800, which is a little above what we're paying now. But based on our most recent conversations last month, we know is still less than the actual costs of the exam. So we have, in working with DOJ leadership, Kayla and I have presented as proponents on the bill, and we're continuing to track its progress. It had a hearing in Senate Finance and Claims after being passed off the Senate floor 42-8, going back to Senate Finance and Claims where they routinely review any bills that have money in them. And we're waiting for executive action from Senate Finance and Claims. The hearing was just Tuesday morning, so we expect there'll be action sometime, but we just don't know what it is.
In the closing argument in that Senate hearing or whatever, the individual who introduced the bill mentioned like an additional $300,000 that was in another budget. Do we know anything more about that additional $300,000? Is that like a one-time thing that hasn't been spent like for this year that then could be rolled in to augment this like in the first year? Or was it just like hey, there's also this $300,000 like
So
random mention of
yeah,
dollars?
so the mention of that, and I want to pull up the statute real quick so I'm speaking correctly about it. But the mention of that is that there is another chunk of money that had been allocated to the Department of Justice related to the use of canines, investigative canines. And that money sunsets at the end of this fiscal year, at the end of June 30. And so I think what he was saying, the best that Kayla and I understood it, was that that money becomes available and goes back to the state general fund at that time and is not allocated in the future. And so I think his point was, either if you're looking to fund this 375 proposal, or maybe he was saying, because I don't remember exactly how he said it, if you wanted to add on, that would be a chunk of money that's not going to be used in this other way going forward. So I think that was the point.
Okay. I also couldn't figure out what he was trying to say about it.
I think that was the point. Yeah. Any other questions about the bill or this process that we're in right now?
I do have one question going back when we talked about the covered guidelines under FREP, and that's only for non-reported cases that are paid for by FREP. Law enforcement doesn't have those same standards, correct?
That's correct. That would
Okay.
be outlined maybe if the medical facility had an MOU with the
Okay.
agency about what the agency would cover. If there's no MOU, there might be some negotiating. For instance, if a invoice came in and the law enforcement agency, I mean, you all probably, I don't know, maybe you don't have the hands-on experience with that because your billing departments are handling that portion, but
Right.
I imagine there are some agreements that outline exactly what each agency is willing to cover and some that might not be that specific.
Yeah, in my head, it was always that they would only cover the cost of having the evidence collected. They wouldn't cover like medications or testing or things like that, but I don't know where that came from, that thought in my head. Maybe someone else shared that with me, but
Oh, I do recall now. So I did reach out to medical facilities, 10 facilities across the state, asking them how they bill law enforcement, just to learn more about it myself. And this was prior to our February meeting, as I was getting information ready for that meeting. And I do recall at least a couple facilities saying that they don't charge law enforcement for medications, for instance. I could go review those notes and get back to you on that. But I think I am recalling right now that there are some differences like that.
and when we talked about Senate Bill 491, it was really, it's pretty vague to me in the legislation about if there needs to be a kit collected, a kit not collected. And I think from a lot of our testimony, that $375,000 will cover the amount of exams that were collected this year, but we also know that they've been increasing over the last few years. And so I think one of the big questions was, is 375 really enough money? And then if you talk about the cases where exam or DNA evidence is not collected, for example, the majority of our pediatric patients, none of those exams would be covered under this if you require that DNA has to be collected.
Yeah, and I think the way the bill is written, you're exactly right. Like, it's very broadly written, so it would not be limited necessarily to paying for exams that have kits collected, but the practical reality is that it's not a big budget. So 375, it seems likely DOJ would have to prioritize what it paid for, or decide what the payment structure would be. Is it first come in the door? We'd have to figure that out.
Would that be a DOJ decision? So I know that them legislature passing SB 491 would then preempt us from establishing rules.
Not necessarily.
Not necessarily
No.
amending the amount.
Right, so the portion of the bill that amends 411, which is the structure of the payment system, it strikes the language about law enforcement being responsible, it leaves the language for DOJ being responsible, and it leaves our administrative rulemaking authority intact. So Kayla and I, just in discussing, have said that, it seems we would have the rulemaking authority to go through and set up what the structure would be, depending on what funding is available and what ultimately happens.
That was my question was, does that then stick with DOJ to make that priority list, or would that be something that we as a committee could do rulemaking on?
I think that's something maybe we'd have to have a legal person look at formally, because both the committee and DOJ have rulemaking authority. DOJ is the one specifically mentioned in the exam statute, in the payment statute. So it might be something we want to have reviewed.
That's the same conversation with, that we wanna have with payment structure, it's just really depends on the budget, so I think it's the same conversation that committee's having. Is to set that priority.
Yeah, and I guess just for those not familiar with the rulemaking process, so that is a very specific process through the Montana Administrative Procedures Act, and we talked a little bit about that, I think back at our first meeting, our second meeting, so it's been a while. But that's a very structured, it's called MAPPA for short, a very structured rulemaking process in which there are very specific stop points for public engagement, the possibility for hearings, there's a public comment window that has to happen with that. So it's not something that the department could just say, this is the way it's going to be. There would have to be a public engagement process. And that can take a couple of months. It can, depending on how quick things are moving, you have to adopt the rules within 6 months of publishing the rulemaking notice, but how fast and slow it moves, it depends on a few specific timeline things. Any other questions around that? Sorry, I'm not seeing Zoom hands right now. I apologize. Does anybody have a question from the Zoom side of things? Well, I'll move on to the next. Okay. I just wanted to let you know the data that we've provided from SARN for the Senate Bill 491 deliberations. We talked about exactly the point you've made, Whitney, with our testimony. The proposed funding level, we think that we could fund and reimburse 468 exams per year at $800. If you simply divide 375,000 by $800, you get 468.2 exams or something like that. We know that the kit track data shows us we did 402 exams with kits last year, which was a 14% increase over 2023. And we did share with the committees, we've been in the Senate Judiciary Committee, followed by Senate Finance and Claims, that we surveyed the 6 highest volume exam facilities in Montana. And just for reference, they conduct about 80% of the kits administered in the state for a reference point. And they said that they had conducted about 270 exams last year without kits being collected, as we tried to think about what exam volume might be. And so, we were supporting the bill and the concept, but also with the data making the point that, this isn't enough. We also talked about, with data related to the proposed exam payment cap, included details in the fiscal note. So when bills have fiscal impacts, they come with a document called a fiscal note that gets posted online with the bill. And we shared in there in our assumptions just that the average exam cost in Montana is just over $2,000 and the median is closer to $1,000 based on my analysis of invoices that were received by FREP for exams without kits collected between 2023 and last month. So I had a little over 50 invoices that were detailed and used those to come up with those averages and medians.
Without kits collected or not reported to law enforcement?
Not reported to law enforcement. With kit collected, with not being reported to law enforcement.
Okay.
Yeah, sorry if I said that backwards.
That's okay.
Yeah. And then I also included the GAO report data that looked at other states' caps and what they're paying, and the average cap was $1,355 and the median of their caps was $1,030. So the legislature has that information in front of them, and I think that that's probably what the Senate Finance and Claims is thinking about right now. I don't know for sure, but we'll see what happens when we get to executive action.
Just a little information for the committee that might not understand why exams aren't being collected.
Kits, you mean?
Why kits aren't being collected during exams. One example is if that person presents to the hospital for an exam over that 120-hour or 5-day window, there is some discretion up to the nurses that they could do an exam with kit collection over that 120 hours, but when people come in 7, 8, 10 days later, typically those exams are not being, or those kits are not being collected. When we talk about our pediatric population, we know the majority of those disclosures are happening at a later time, sometimes weeks, months, years later. And so if we have someone who comes in a month later or 6 months later, those kids are not being collected, but they're still should be offered a medical exam to ensure that their health and well-being is okay. It's really important for their healing process. Some other times that a kit is not collected is maybe the patient is there and we're starting to move towards collecting a kit and they decide, I'm just done. I need to take a break. I need to go home. I need to take a shower or eat or something like that. And we advise them that they can come back, and sometimes they do and sometimes they don't. And then I would say lastly, one of the reasons that I can think of off the top of my head is maybe an assault occurred where there isn't any method of contact that would relate in or would experience DNA transmission. Maybe that was touching, which we can still collect some swabs based on touch DNA, but if there wasn't any like ejaculation or something like that, then that kind of is limiting our ability to collect the DNA swabs. And so just some background information for people, because I think sometimes when people say they're having a sexual assault exam, they automatically think that DNA swabs are being collected, and that's not always the case.
Appreciate that context. So coming back to some of the follow-up information y'all were interested in after our February meeting, looking at the GAO report, you'll recall it was the 50 states and how they're providing access for exams and paying for those exams. And specific states that you were interested in hearing more about were Utah and Massachusetts, North Dakota, New Jersey, and Virginia. And I was able to talk to someone from each of those states with the exception of Massachusetts, but I have a little bit of information from them and I can come back at a future meeting and provide more. I'm just going to briefly run through what I learned about each of those states. So in Utah, their examiners are set up very differently than ours. They have some facility-based examiners, especially in rural areas where the distance is just so far. But typically in Utah, exams are provided by a third-party entity that employs the nurse examiners and dispatches them to the medical facility where they're needed. For pediatric cases, Primary Children's, which is a leading pediatric facility in Utah, they are the ones who are hiring and training and peer reviewing those examiners to provide really consistent high-level care. And I know Brenda particularly likes that model just because of the, Brenda, what's the term? The sub-board specialist that oversees those folks to ensure that high quality of care. Did I get that right?
Yeah, pediatric child abuse subboard specialist.
Thank you.
Dr. Lasky is phenomenal, and she runs their primary children's like abuse specialty clinic and programs.
She's oof, I've had her testify in a child abuse case and she is wonderful. Absolutely top notch.
Yeah. And as Brenda has pointed out, and I can't remember if she's done it in the committee, so I'll just repeat it. Montana does not have that level of specialist. And so it's just something we lack here. But sorry, Brenda, were you going to say something?
I was just going to say, if you were talking to Penn State, their doc, Lori Frazier, kind of started the program in Utah at Primary Children's. So there's some continuity with that as well.
Very cool. And so children can go to Primary Children's and have their exams at that facility, but Children's will also send out examiners to local facilities or to their version of CAC. We call them Child Advocacy Centers. They call them Children Justice Centers, if I'm recalling correctly. And so that's how pediatric care is happening there. They are funded by state general funds and federal VOCA grants. So they're doing that combination. And then they are one of the states providing STI follow-up care specifically that's paid for. And that would include any exams, lab testing, medication, including the HIV prophylaxis after the initial forensic exam. And there's no time limit for that follow-up care and coverage of that care. So that's something that I've found so far that seems a little unique to them. Virginia has some follow-up care that I'll touch on here in a bit, but they have a time limit on theirs. Utah's is no longer limited. It used to be limited to 90 days, but it's not anymore. And then Massachusetts, Brenda had specifically asked about them because she was interested in the way that they were caring for pediatric cases versus adults. And I was not able to talk yet with somebody in Massachusetts. And so Brenda, feel free, if you have some additional information you want to offer based on what you know from your colleagues there. But what I found online on just their program information is they have a separate pediatric kit with specific pediatric forms, which is something we don't have here, though we've talked about it. We talked about it with the last round of improving the kit, and we just weren't ready to get there. We needed some more information, so we'll look at that potential for a future round of kits. But they use those pediatric kits for patients who are 11 years and younger, which speaks to that age piece that we've had some conversation around. And also that they present within 72 hours. So that timeline, I don't know if that's hard and fast, but that is what's listed on their website of when they use those pediatric kits and collect them. Anything you'd want to add about Massachusetts, Brenda, based on what you're aware of?
Only that I'm sorry I didn't connect you with the person I told you I would connect you with, so I will do that.
No, it's okay. It's all good. We've all had a lot going on. And I did make some reach outs there, and it just hasn't happened yet, you know. So no problem. In New Jersey, their system is such that their nurse examiners are employees typically of the county attorney's office. And they sometimes have a deputy forensic examiner as well, employed by the county attorney's office, depending on the volume of exams there. But those county coordinators, each county has one, there are 21 counties, and then they themselves or nurses that they're contracting with or employing are dispatching to the location where the exam is needed. And state law says it's the hospital's responsibility to provide the location for the exam. It's the county attorney's responsibility to provide the examiner. And the funding source, so you'll recall New Jersey was the one that had that $800 penalty charged to offenders. And when I talked to the coordinator there in New Jersey, she's been with them. She was in the first program 30 years ago that got built. So she's been there a long time, very knowledgeable, Eileen Allen. And she said, in reality, that offender penalty is so far down the penalty list that it's rarely asked for in court. And so I think that was a comment maybe Celine, somebody had made at the last meeting, or Eldina. So it's rarely charged, but when it is not enough to cover really much of their costs. They're using it to supplement some training costs for nurses, but really what they're using is $3 million in VOCA funds to pay for examiners, supplies, equipment, some of their travel and training. And then they have a line item in the Attorney General's office budget for $4 million roughly, that's state funding to pay for forensic nurse examiner on-call pay. And she said, I don't know how they got it done, but it's $16 an hour they're on-call pay, which she said was incredibly high. And it takes a massive part of their budget to do that on-call pay. But they're also paying, I see Emily's struggling over there.
Another piece of information for the committee, in Montana, they make anywhere from nothing to maybe $5 an hour to be on call.
To be on call, yeah.
Yeah. And then New Jersey also pays, so these nurses are dispatched. If they're dispatched and then maybe the patient changes their mind before they arrive, or they arrive and it's determined it's not actually a sexual assault, or whatever the circumstances might be, they're still paying them, I believe it's $100 just for being called out and for minimal paperwork. And then if they do a full exam, there's a higher reimbursement that they get for that exam. And again, that $4 million, they use those forensic examiners that are on call for all types of cases, not just sexual assault.
Talking about the being all housed out of one facility and then dispatched, I think that's a really great idea. And then you think about in Montana, geographically, how that wouldn't work.
Well, it's by county still in New Jersey.
Oh,
so it's
okay.
not central, it's by county still.
Okay, because I was thinking, I'm like, you could fit 50 New Jerseys in Montana.
You're right. Even from central Jersey, it's not hard to get to the farthest points of the state quickly.
Right.
So, yeah.
Oh, okay, so it's by county.
Yeah.
Okay, interesting.
Yeah, and 21 counties. So
It's a lot of nurses.
yeah, and so then Virginia, who I was just able to connect with their coordinator yesterday, she was very very great to talk to. They all were. I shouldn't say that just specific to her, but I appreciated, she's been juggling a lot of things. We were finally able to connect yesterday. But she said their examiners, most are in a hospital, ER, healthcare system setting, but they do have some that are contracted. So they will have some of those there. She said there's a handful of those that aren't based out of a hospital, ER, healthcare system. But those handful, they have some unique circumstances. One is based in a hospital, but serves multiple locations and child advocacy centers. They do have some standalone programs like a private urgent care that has a SARN there at the private urgent care. There's a group that does have an MOU to dispatch to hospital and clinic settings. And so it's really kind of a combination of things, but she said predominantly it is much like Montana, where there's somebody based in the medical facility that a patient presents at. Their exam payments, they had one of those really substrated structures for their exam payments. They pay, that says $60, it's 60% of actual costs for acute exams within 120 hours. So again, 60% for exams within 120 hours, no cap. And then for exams that are not acute after the 120 hours, they will pay $1,500 of the actual costs, but they always pay 100% of medications regardless of any of the caps. So that is something they always cover. And they do have an opportunity for follow-up care. It's not specific to STI treatment, but can include that. That follow-up care is capped at $1,000 for the follow-up care, and it needs to happen within 90 days of the first exam. So a little bit extra that they're doing there in a different way. And that was the roundup that I brought to you thus far. Happy to answer any questions, have more conversation about things you're interested in learning from these other facilities or states based on either myself or what Sarah shared today. As you think about what Montana might consider in the future. And having Senate Bill 491 hanging out there kind of, you know, we don't know where that's going, but it's still good to keep going with this conversation. I think there's probably, if there were a scenario where Senate Bill 491 is passed with a bigger budget, it still leaves room for this committee to talk about what's that payment structure maybe look like within that budget. That might depend on whether the bill still says it's $800 per exam or not, or if they give us more wiggle room to figure that out as a committee. I don't know where that might go, but I think it's important just to keep having the conversations.
Currently, the bill says up to $800,
Don't recall off the top of my head.
maximum of $800. Okay.
Yeah, the difference there is that right now, it's managed within the arms, the administrative roles, but this would codify it. So, you know, that presents its own challenges if it is in statute versus rule, because we have a lot more flexibility as a department just to change to the structure that the committee decides on within rule versus. Thanks so much.
Brett, I see you've got your hand up.
I did. The one thing that kind of strikes me through all of this is it seems as though, you know, fiscal notes and the cost is really what drives a lot of this. And with that $800, do we have maybe you said it and I missed it, but what's the typical cost of getting this done? You know, and I would imagine it would vary whether or not it's somebody in-house at the hospital or, you know, travel and all that. Do we have like a range of what it costs to get a SAN exam done generally across the state?
Yeah, I don't know if I could call it a general range, but in looking at those invoices that Prep has received, they were the ones where it was a detailed invoice, not a lump sum invoice. And there was a link in your meeting bug also to some sample invoices for you to take a look at. And some of those show how expensive exams can get in some circumstances. It really depends on the extent of injuries, because even though we're not paying for the cost of treatment of the injuries, the diagnostics on the injuries really is part of the evidence collection. And so you'll see in some of those sample invoices, there's radiology, which I assume maybe somebody was concerned about a broken bone. Potentially there are, another sample invoice with an EKG, which I'm not sure if that would be related to a strangulation case maybe, or what would be the circumstances, Emily?
That would be
you
more like
be
blunt force
attracted
trauma to the chest.
Blunt force trauma. to the
Whereas like
chest.
the imaging may be more of like a strangulation, because gold standard is everybody should get a CTA of head and neck following strangulation.
Mhm. Yeah, and so we have an invoice that included radiology that it didn't say what kind of radiology, and there's another invoice in there that is specific to a CT scan, which would correlate to the strangulation case potentially. And so, and we shared that with the committee. I think it was the Senate Judiciary meeting in which that question was asked, or maybe my days are all blending in and that wasn't the conversation. But
No, it was the first meeting.
was it the first
Yeah,
meeting?
it got,
Senate
it came-
Judiciary?
got brought up, yeah.
Yeah, and so Brett, when I looked at those invoices, and I had a little over 50 of them going back to the start of 2023, it really ranged. The lowest cost were the lump sum fees that medical facilities are charging, like the $600 that they know PrEP can pay. And so they're just simplifying their billing process and sending us that $600 exam fee. Other simple invoices there are a couple of facilities that charge more than that. One was a little over $1,000, and it's in the sample invoices that I shared with you in that link, but they code that simply as ED, so emergency department legal services. Other facilities have separate charges for the emergency room, treatment room, versus, I saw one exam there, and I think I used that one in the samples that you received. That there was the exam room itself, and then there was another code for an ER treatment room, where when there was a supplement document that I didn't include for you, but it looked like they got some sort of IV in that treatment room. And I don't know if that's because that's where the IV could be administered, or if there's more privacy, or what the circumstance was.
Sure.
But what we see is it really ranges. When I did the average on those 50 plus invoices, it was just over $2,000 average. I did run the median, which was closer to $1,000, because those higher cost invoices can drive up the average. But I think, what I saw in there is that the average is around 2,000 and the median is around $1,000. So. I don't know,
Thanks.
or Whitney, if you'd want to talk more about that from your perspectives.
I think it would really depend on like what we're doing with the patient. Like if we have a patient who only wants the kit collected, a pregnancy test, and medications, that bill is going to look much different than somebody who we're going to run a syphilis and HIV and hepatitis series, and then maybe give hepatitis immune globulin and give a hepatitis vaccine if they come back as not considered immune. And so there's just so many factors that could drive that cost up that it's really hard to place an average on that.
And then the other thing we know specific to HIV prophylaxis, the NPEP treatment is exorbitantly expensive. It's about $2,000 itself to get the higher than that, Emily's saying. And so a lot of the medical facilities, and I haven't talked to all of them, but the ones I've talked to, half dozen to 10, they're for that NPEP charge. They're finding lots of creative ways to try and get that paid for, because NPEP would be the gold standard treatment for a patient who has a blood exposure or other types of bodily fluid exposure. But it's so exorbitantly expensive that can be a real barrier to somebody feeling like they've got the treatment they need to be as safe as possible. And so some medical facilities have a trust or a foundation maybe that's helping offset the NPEP cost. I'm forgetting, there's another organization, I think they have an endowment fund that they're paying for those costs out of specifically. So medical facilities are getting creative with trying to provide that NPEP because of the cost.
I think something that's important to think about too, when you're looking at these invoices, is there's not a charge on there for the forensic nurse. And so when we talk about reimbursement for these exams, that's really talking about the reimbursement for the care that the patient receives and the medications they had and the testing they had. I really don't think that there's programs across the state who could be sustained based on this reimbursement rate. It's not enough to cover the on-call rate for nurses 24/7, the time to come in. Most facilities either offer them time and a half or a stipend to come in. Because like Sarah had talked about, a lot of these nurses are working a primary job. And this is something that they're doing extra. And so when we talk about the reimbursement rate and then the ability to have a sustained program, I think there's a huge gap in that. And sometimes in the ER room, they can funnel the forensic nurse charge into there. And I did see one that said like a specialty provider or specialty treatment, but in reality, there's not a charge that says forensic nurse came in for this many hours and that gets billed to that.
Do you think that that's in any way tied to kind of difficulties in recruitment and retention of, say, nurses? Or are they getting paid in the back end? It's just not through these avenues.
Yeah. So I think they are getting paid. If the hospital is making that a priority, they are getting paid in a different route. So like take, for example, the hospital that I work at, we are grant funded for only our nurses' salaries. So that covers our on-call rate, our time and a half, and then we get a stipend when we come in. And then it covers my salary as a forensic coordinator. None of that grant covers anything to do with patient, like the actual patient bill that they're getting. And so that's where we're getting that reimbursement from. So it's
I'm
kind of
with you.
like two separate pots of money.
Yep.
Recognizing that grant funding is not guaranteed and all of the things that come with it, or it's not a long-term solution. Some hospitals are not grant funded and they, have that in their budget and that's something that they take priority in, or they're able to take priority in. I think one of the things that we talked about when Senate Bill 491 was being brought up was if this law comes in and there's this single payer system and this reimbursement amount is increased by $200, that every victim's going to be able to get a SARN exam in their community. And I don't want to be pessimistic, but I don't think that that's really the most honest thing. Is I don't think small town facilities can maintain a full-time forensic program off of $800 for maybe 10 patients that come in a year. Just the operating costs are so much more than what they're getting from that. And so that's another conversation, but it's great, but we recognize that it's not the miracle that people are hoping for.
And in terms of like the retention, I think we also have to consider these small facilities that see 2 to 10 patients a year. What backup do those nurses have? Like who is precepting them or who's reviewing their charting so that they can feel confident when they go in to do those exams? And that's why I think a lot of people leave the profession, is because they don't feel supported in the work that they do, or they don't feel confident in the work that they do, and they feel like they are not giving exams to the best of their ability. So it's better in their mind to not do the care than to give crappy care, or what they view to be crappy care. And having $800 for 10 exams isn't enough to build that robust training program that keeps them in the education to feel confident to do those exams when it's been 6 months since they've last seen a patient.
Yeah. Oh, sorry, Derek.
Give me, this might be a really dumb question, and that's okay. Being from an outside view of kind of the overall program, have you guys ever considered doing a level 1, 2, and 3 saying nurse program, such as having grown up in Wolf Point, Montana, you've got X amount of available nurses to do that. But a level 1 can be evidence collection, et cetera, that gives them that capability to do it on the front end of it, and then maybe a level of repayment on that based on the services that they're providing, and then break out the larger regions to a more trained nurse, or maybe a second or third level. Is that something that would be possibility? I know the ultimate goal is to have a level, the top level full exam every single time, but is that something that would help at all the program? Again, maybe it's a stupid question and please call me on the carpet.
I'm not necessarily thought about it. I know I used to work in North Dakota and their reimbursement rate is based on, it's like a tiered section. It's not based on what type of nurse did the exam, but if they met with a patient and offered them medications, they get reimbursed this much. If they met with them and they did a visual exam, they get paid this much. If they used a special camera, they get paid this much. If they collected a kit, they get paid this much. So I've seen it that way, but I haven't seen it based on necessarily the type of nurse doing the exam.
And also like trying to think about it that way, like if they went to a facility in Wolf Point and they were like, yep, but we can only offer you this level like 3 exam, which would be the lowest level possible. We can do that here. And the patient says, okay, but then they change their mind and then they want to go someplace that has a level 1. Now this patient is also getting 2 exams for the same assault. And we have to think about the re-traumatization in that. And like how does that best serve the patient in that time frame?
And I know we're just calling out Wolf Point, but I do want to give kudos to a couple of really great nurses out there at Poplar Community Hospital and Trinity Hospital, serving them and providing great care. There are 2 trained nurses, one of whom went through the DOJ training last spring. So we're glad to have them on board.
Yeah.
But Derek, to your point, I mean, that sort of consideration is something that's absolutely within the committee's purview to consider, of how, what should an exam structure be? How do any guidelines, because the committee has authority to establish education and medical guidelines for sane care in Montana, should it choose? These are the kinds of questions that as you build guidelines and protocols like that, that, could be considered in something like that. Yeah. Any other questions, comments, feedback? I'm looking at you, Christina. I feel like you got something percolating there. And
Christina's always got that look in her eye.
And just putting the structure together in my head. And once it's there, then, we'll slap it out on the table and go, what about this? Right? I think the question will be, sort of, it's more leaning in my thinking, and it's probably wrong at this point, but for how to get that basic capacity to, as part of onboarding of nurses, very basic capacity, and then be able to think through the advantages of telehealth programs. I don't know that we're really going to be able to do a high level in all our hospitals. And I don't know that we necessarily have to.
Well, and I've said it before with the committee, but just for anybody who might be listening to this now or later who's new, the kit is built with very detailed instructions with the intention that any medical staff licensed person can take it off the shelf and use it and administer it and collect the evidence in a good way. And that's really what it was built for. It was built for to weather any kind of scenario and help somebody through that examination. We know that the gold standard is to have someone who's been specially trained specifically with the victim-centered, trauma-informed approach. But trying to find the way, I think we heard Sarah say in her presentation, there's not really a one-size-fits-all approach that she's found in any of the literature review from other state structures. So,
and I think I would make the argument, Hope, that the trauma-based is a mandatory piece of what we have to have at the end, because that's the only piece that we have that we know the brief of traumatic informed intervention. We know that is going to be the one that is going to have a long-term health consequence. We don't know that the very best medical intervention is going to have a long-term health consequence. We know that the traumatic intervention is going to have a long-term health consequence. I don't think we can omit that out of, any baseline activities that we recommend.
And I think looking at the history of forensic nursing, we know that once upon a time, forensic nurse exams were not overly trauma-informed care, and they did whatever the box told them to do. And there are horror stories out there of individuals who experienced medical trauma at the hands of having this forensic exam done, and it made it feel like they were being assaulted all over again. And so I do think that trauma-informed consideration piece is huge, and that's why it's such a big aspect in the training that forensic nurses undergo. And so I love the fact that the kit has all of the directions in it, but it doesn't like have the compassion and consideration for the trauma that the patient is enduring, or that they have endured as they come into our care. And so sometimes I think it's very dangerous to be like, yep, we have all these instructions so that people can just go do it, because are we doing more harm than good in that instance? But it also, like, you have the individual with the right heart who will go in there and do what the patient wants. That's amazing. And it's great that somebody can pick up the kit and run with it. So I think we also have to balance that as well.
When I've heard the reasons why nurses don't want to do these exams, because at the facility I work at, before they had a program, the ER nurses they had some training, and they would be performing the exams. And one big thing was, I don't want to go to court. And that was like one of their big fears, that they were going to collect something wrong and the case was going to get lost because it was all based on this evidence that's collected and it's all the nurse's fault. And like, just reiterating to them that there's so many different aspects of this case that it does most of the time does not come down to a DNA specialty thing. There's other things on interviews and witnesses and, you know, corroborating evidence, that it's not all on the shoulders of the nurse, but really trying to get that through their head is really hard. And they have had experiences, or their coworkers have had experiences where they did do an exam, they weren't a SARN nurse, and they did get, you know, ripped apart by a defense attorney who said, you know, you're not even really trained to do this, and you've never done you've only done one before in your career, and do you really think you're doing a great job? And I think that really carries in the nursing profession of that experience. And yeah, like the kit has all the instructions, but it doesn't have like, take a deep breath. The chances of you testifying is probably really slim. It's gonna be okay. Like, there's not that pep talk that, you know, I, as a forensic nurse, I know that, but, you know, someone who's not in that role, they don't know that.
And I think also overcoming the fear, like when you're in nursing school, they tell you over and over again, if you land up in court, you did something wrong.
Yeah.
Like, that is part of our standard education.
It should be.
I'm pretty sure in the SACE trainings, when you guys did debrief with the students, that was a theme that came up, is like, we are scared of court.
Yeah. Yeah.
It's a
So it
huge
still
concern for
exists.
staff. Yeah. And there's also a number of people who are like, I don't want to be the one who collected something and then it's going to send somebody to jail. Like, they are like, then they feel responsible for ruining somebody's life, and they can't separate the fact that like that individual did a very dumb, bad thing, and that is what ruined their life. You just collected a sample. But in small towns, it can be really hard to break that mindset.
Well, and the HRSA grant team, if I'm recalling correctly, I mean, part of one of the modules they want to build is working on that court piece to help make it less scary, building an education module that relates to that, to help support nurses, to help take away some of that scare factor. I think it's also worth mentioning, you know, part of that same training grant is to build a peer support platform and network to help support those who don't have very many cases, and we're doing that together in somewhat rudimentary ways right now, with y'all supporting each other in our quarterly meetings with people who trained last year in the DOJ training, and just for the committee's awareness, we're about to merge quarterly meetings that I've been hosting with those who trained last year in the DOJ funded SARN training with the MSU efforts to create, you know, what will be phase one, or the ground level of this platform, in which we're getting all the nurses together with opportunity to learn on a fairly regular basis, you know, to incorporate some peer support, but also stress debriefing, using licensed therapists and things to help support those folks. So I think we're on the cusp of really doing some cool new things to support Montana's nurses in that way. Like we're building it out right now, so we don't know exactly what it looks like yet, but we're there in terms of being at the ground level of building something new. And I think that's pretty awesome. So I thank everybody here for being part of that. I want to pause here and see if we have any public comment. This is the time on our agenda where a member of the public who's attending may comment on anything within the committee's jurisdiction, whether it's something you've heard about today or at another time or whatnot. It is not a Q&A back and forth, but any questions that you might have, you could pose during your comments, and something committee could consider taking up in future conversation here. So I'll just open that right now. And if you have a comment you'd like to make right now, please press the raise your hand button at the bottom of your screen so that we know you're interested in making comment, and I will unmute you so that you can. You can also always email comments to dojsarn@mt.gov if you want to share your comments that way, no problem. Not seeing any hands raised at this time. Give it 30 more seconds. Well, I'll just go around the room here and ask for our standard sort of committee reflections, thoughts as you think toward our next meeting. I want to check in. We don't have the full enough group probably. We have had a conflict come up with those June dates, the week of the 20th. I forget which dates we had said the week of the 20th. So we're probably really looking at June 27th and 28th for that June in-person meeting. We've had feedback both of doing one long day or breaking it up between days so that someone could travel in the morning and then travel home the next day after we finish around lunchtime. Any particular thoughts right now on the structure or dates for our next meeting if we're looking at June 27, 28?
I like the half days because it's a lot of information to take in and a lot of, I mean, sometimes heavier conversations to have, that I do like the half days, but I also recognize I live in Helena and it doesn't really impact me a whole lot.
You could sleep at home.
I can walk regardless.
The 20th is a Saturday.
Yeah.
I must be looking at the wrong dates.
The
Sorry.
26th, 27th, maybe?
That must be what I was looking at.
I also would endorse half days, but very selfishly because I will be joining via Zoom from Arizona and vacation.
Yes.
So
Are we looking at doing in person for that one?
That was the idea. Yeah.
Yeah, okay. Yeah, right now I could make 26th, 27th work. If I get it on the calendar now, I might be able to save it.
Anybody else?
Actually, those dates, I will be heading to South Dakota for my son's wedding, so I will be unavailable on those dates.
As you should be. Yes. Okay.
I
Jean?
know, I have, summer's really tough.
Yeah.
I have a memorial service I need to attend, and then I have a couple vacations as well. For the vacation part, I can definitely pop in via Zoom, but summer's a little tough for me.
Well, now that we're a little closer to June and we know that that week of the 20th doesn't work for a conflict that we've got here at the office, maybe I do send out an updated poll and we can look at other potentials in June. We're just trying to beat July 1 when the fiscal year starts over. We'd like to meet before that to make most advantage of our budget. But I mean, if we need to look later in the summer, we can. Should I send out another poll and just kind of with the updated dates now that everybody knows a little bit more about what's going on with their summer too? Okay.
That'd work.
All right, we'll do that then. Just an FYI, other program updates, we have the prosecutor training coming up for state, tribal, federal, city prosecutors to strengthen sexual assault prosecutions, April 23rd through 25th in Helena. We've got about 25 people registered right now, so that's great. We're feeling good about that. Had an opportunity to do outreach this week at the Montana Coalition Against Domestic and Sexual Violence. They had their conference in Helena this week, and so we tabled both yesterday and the day before at that event all day, and met with folks from around the state from the victim advocacy world. So that was good connections made there. And I did a webinar recently with some college campus outreach and their Title IX offices and various sexual assault prevention programs. So working on that. So just a little brief update. If we go around the horn here, Jamie, anything you'd want to share with the committee about what's been going on in your world, or any reflections or comment on today's conversation?
Well, from the Crime Lab stance, we brought on 2 new DNA analyst in interpretation. So they are able to write and review data, which already in the past week has been amazing. So they've taken cases and review. It's been great. So they'll continue writing and interpreting. And then they'll work towards their laboratory analysis training as well. As far as reflection, I always, I enjoy there's so many different pieces to this puzzle. And so hearing from the FREP side and the financial side just kind of gives me a new appreciation and just kind of absorb it all and take it all in.
Thanks, Jamie. Mark?
I just wanted to thank you and Sarah for the presentations. Those were great. And if you two wouldn't mind sharing your slide decks, I would appreciate that. Thanks.
Sure, we can do that. Let's see, Ben.
Just really good conversation today. I think, just from the administrative side, the telehealth just intrigues me on how to implement it. I'm just trying to picture the patient side of completion of the exams. That's the hard part that I'm trying to get around. It's so much different than other telehealth exams. That's the hard part that I'm trying to get around. And that's the part that I'm just trying to wrap my head around. And that's where I'm struggling with it. But it's intriguing to me, but I'm just trying to wrap my head around it.
Ben, I recently shared a telehealth toolkit from the International Association of Forensic Nurses with Mark, and he graciously went through and looked through that. Why don't I send you that link as well, just to maybe help you percolate your thoughts as we work toward that part of the discussion.
Yeah, that would be perfect. Thank you.
Okay. Brett?
Yeah, I thought both were very good. A lot of information. It's just making me think about the funding, because seeing what they do in New Jersey, all I see there is it goes to the counties pretty soon. The money has to come from the counties too, and we're hoping that it gets funded, or we're relying on VOCA grants specifically. That just concerns me a little bit. That's not obviously what they're trying to do right now, but it'd be wonderful to have funding in place, going forward, that we didn't have to come back over and over and try to, reconvince the legislature that it's necessary. So I guess with whatever we do, I hope we can get it to a point where it's funded long term, so that we can have some stability in it at least. That's kind of what I've been thinking about.
Brenda?
Thanks. So, yeah, thanks for the presentations. It was very good information. I really appreciate all the research and stuff that you do, and the information that Sarah shared is very helpful. I just emailed you that thing on Cortex Flow Live, if you're interested. I am super excited that we have legislation to fund exams, because I think not only does it alleviate law enforcement burden, but I think more kids, adults, adolescents will get exams. So that's exciting to me. Is it possible to get information about that Billings pediatric flyer? I apologize if you sent it out or if I should have seen it, but I'd like to know more about that. And then you know, with Sarah's presentation about state laws and stuff, I guess what I just wanted to say is that, you know, the national standards for CAC accreditation does have a medical component that does set out initial training requirements for medical professionals, ongoing training, a lot of different components to that. So in lieu of state legislation, if CACs are accredited, they are at least following those guidelines for the pediatric and adolescent. So just as a resource to know that they're in a different way, there are some established guidelines out there, and they are established by the subboard pediatric specialists, and CA convenes groups to do that. So I don't know if that's helpful or not.
Well, I appreciate hearing it. Thank you. Christina?
Yeah, I thought the information was great, you know, that these always leave me with the thought of how much commonality there is across disciplines in terms of need. That, you know, this one that I left with trying to go, you know, okay, that as I said, I really think that it's that trauma-informed, trauma-based is a pretty misunderstood thing still at this point. And I have to say that I find it to be like a piece of magic, because I think that I think it's one tool that makes it so that our people can all across all the disciplines walk out knowing that they helped. That's, you know, that there's just enough, research and evidence that shows that those well done brief interventions right at the front end make the difference in the long-term health outcomes of our victims. And that, you know, so that I'm going, you know, so how can you use this across all of the disciplines and just make it, because I think that would settle down with them being able to say, well, I know I did a brief intervention well, and now I'm walking out going, because they just want to do things well, right? We just want to be useful. So as long as we have a way of giving all of our people a way of knowing that they would be useful, I think we can also move the industry, or the whatever we call ourselves, forward collectively together. And I do think that, you know, that it would do something to mitigate the other commonality that we heard about in today, which was the fear of, you know, of court cases. That I think that some of that, you know, is reliant on, did we do everything perfectly? You know, as opposed to, is our presentation done in a way that we believe we did the best we could do? And that's how we come across in court. Because I think that fear of not coming across in court as though you did everything perfectly is, you know, very often just the thing that gets them, you know, gets people slammed, because they can sense that insecurity. If we can, you know, if we can put it in our people that they did it right, you know, if they didn't do it right, then we know where that sits. But in general, that they did it right, that I think that we can address that in all, across all the disciplines. Because, you know, advocates, I mean, you get that with advocates, you get that with mental health, you get that with the nurses. Nobody wants to go to court because they just don't want to be ripped apart, because we're all sort of like a little perfectionist and going, did we do that well enough? You know, and we need something in our system that goes, yes, you did that just fine, you know, and then go from there. But you did just fine.
We all kind of need daily affirmation, don't we? Somebody been listening to the Snoop Dogg affirmation song. I've been listening to the Snoop Dogg affirmation. Sorry, that's an aside. If you haven't listened to it, Google it and listen to it soon. I'm going to turn to the folks in the Helena room here. So Celine.
So I've been stuck kind of like on the kind of the same level as Christina right there. And I've helped train with child forensic interviewers. I've helped train law enforcement. Like brand new baby cops coming out of the academy, we always provide a testimony element to their training from the very beginning, because we know that's going to happen. And I just keep thinking, is that something we can implement in some of these same trainings that are happening around the state? You know, Brenda's been there when we've done the child forensic interview trainings, and we do you know, a defending the forensic interview presentation and how you should testify and what the big things are and what's important and what's not. And then we do, you know, 10 minutes of a direct and 10 minutes of a potential cross-examination where you kind of see how bad it can get. And I just love the idea of extending that, because the last thing I as a prosecutor want is somebody to be terrified to come to court when we're not normally calling you because you did something wrong. We're calling you to connect the dots. And it's part of the bigger picture. And just like we tell our victims, when they testify, everybody plays a small role. And I hate that there's that level of trepidation.
Well, consider yourself signed up to assist with the MSU development of the module, so.
I figured that would be coming when I had to say it.
Do I get to start or?
Go
do I-
ahead.
Oh, I just want to
Go
say
ahead.
something off Celine first. When we did our Montana training last year, we did have an attorney come in and talk about that, but I think what Emily and I were talking about is it's our basic nurse, not a basic nurses, that was wrong. If any nurse hears me say that, they're gonna be so upset. The nurses who are not in this field, the ER nurses, the bedside nurses, the other things like that, where from nursing school, when we haven't even decided we're going into forensic or the ER, the ICU, they say, you're gonna end, if you end up in court, it's because you did something wrong. And so I totally agree with educating forensic nurses, but it's something that we have as like a nursing issue, not a forensic nursing issue, that you're gonna end up in a courtroom because you did something wrong. If you don't document that, it didn't happen, and then it's gonna be back on your fault. If this patient dies, it's because of something that, you know, that you didn't document or something like that. So, but yes, no, we definitely will sign you up for all of the additional training.
My boss is gonna hate me.
I just reflect on, it's really interesting to see how other states do it, because we know it's not a one size fits all. And I think with all of our education and our talking and our teamwork, that we'll find something that works for Montana. I think a huge thing is just having this committee and bringing these conversations to the surface and making, you know, even if it's just our group, we're more aware of the situation and the resources and the lack of resources that we have in our state. Kind of going off what Brett said, I really hope that his forecast of the future doesn't come true, where this funding comes back on the counties, because I think that's the exact same problem we have right now with the funding on law enforcement. You know, we have those small counties that might not be able to afford this, so I'm putting it out there that Brett's idea is not going to come true, so there's that. And then, I think telehealth, like, Ben had said, is really, really interesting. There's a few different ways you can do it. I've worked with a couple of programs that I would love to connect Hope with, and maybe we can have someone come in and talk about how they run their program, just to give us one idea of it. I've seen it where it's run out of a facility. I don't know if in Montana that would be a hospital, or if that would be out of something more statewide, like the Department of Justice. I've seen it where the telehealth nurses are consultants for that ER nurse, where they just kind of provide some guidance. Then I've also seen it where that telehealth nurse does everything that they can, except for actually doing the swabs, where they instruct the ER nurse how to do it, but they do all the questioning, all the report writing, they can see all the photographs on their computer at home or wherever they're at. And so I do think even with the telehealth, there's not a one size fits all. And so I think it'd be really interesting to see what we come up with for the victims in Montana.
All right, Emily?
I don't know how to follow that. I feel like she said all the things. But definitely appreciate the information provided. And having worked in other states, like every state is so different. And even like states in close proximity, like having done cases in Idaho, Wyoming, and Montana, like nothing functions the same between those three states. And so being able to pick out what we like from other states and seeing how that fits in our state, I think is going to be really helpful as we try to build something that can be useful for every community in the state.
Any other thoughts, comments before we adjourn today? I just do want to share that I heard at the coalition meeting this week that people are watching our committee. They're going onto the website after the meetings and checking up and going back and listening to the old meetings. So I just want you to know that even if they're not here today, they are listening to these conversations and your work is having an impact. So thank you for being here and being part of this. And we'll get another poll out for those June dates to clarify that. I do think we'll be spending a chunk of time on the telehealth part of the conversation at the June meeting. And we'll know more then too about what's going on with the payment structure discussion. And I'll continue to keep you posted on what's happening in the legislature so that you're on top of the latest. If you have any questions, don't hesitate to reach out in the meantime. And hope you're got some fun spring plans coming up. Happy spring. It's officially here. So take care.
Thanks, guys.
Thank
Thank
you.
you.
Thank you.
Thank you.
We don't have another